So everyone, Dr. Gelman is one of our GI attendings here at Morningside West. He's doing us the great favor of being here with us today to talk a little bit about lower GI bleed. So everything's the same setup. You can go ahead and start whenever you want, Dr. Gelman. Thank you so much again.
Oh, you're very welcome. Thank you for inviting me. So for today, we're going to talk a little bit about lower GI bleeding, and I have no financial interest in lower GI bleeding at all. So we're going to talk about I think first of all, we're going to talk about the general approach to GI bleeding. Then we'll kind of focus a little bit more on lower GI bleeding. We'll talk about some of the more common specific etiologies of lower GI bleeding. And then we'll go a little bit into how we, diagnose and treat lower GI bleed. And then we'll try to blast through 5 cases. So let's first talk about the general approach to GI bleeding. So when you're faced with a patient with GI bleeding, the 3 things to focus in on are to try to localize the site of the bleed, to try to assess the severity of the bleed, and that's basically assessing the hemodynamic status on presentation, and also an assessment of any ongoing bleeding, and lastly, to resuscitate the patient. So let's talk a little bit about localizing the site. So GI bleeds are classified into upper GI bleeds, small bowel bleeds, and lower GI bleeds. So an upper GI bleed begins proximal to the ligament of Treitz. And suggestive signs include melena, vomiting red blood, vomiting coffee grounds, or a BUN to creatinine ratio of greater than 25:1. Melena specifically is black, unformed, sometimes called tarry stools that have an extremely foul and distinctive odor. A formed black stool is not melena and does not have the localization value of melena. And the reason for that is that there are several things that can produce a dark or even a black formed stool. There are several foods such as licorice and blueberries, and if you're in England, blood sausage, and several medicines, charcoal for one, Pepto-Bismol, and of course iron. It takes about 100 to 200 cc's of blood to produce melena, and it takes about 50 cc's of blood to turn a stool black. And as I said, that can be formed. So small bowel bleeding originates anywhere between the ligament of Treitz and the cecum. And we presume to have a small bowel bleed when a good quality upper endoscopy and colonoscopy did not reveal any candidate lesions. Lower GI bleeding originates from the colon, and a red or maroon stool is suggestive but not definitive for a lower GI bleed. A series of 80 patients was studied passing red blood or maroon stool. 74% were found to have a bleed of colonic origin, 11% had an upper GI origin, 9% had a small bowel origin, and in 6%, no source was identified. So most, but not all of them, were colonic bleeds. Red blood per rectum from an upper GI bleed is always accompanied by hypotension and hemodynamic instability. So if you have a patient who's passing red blood per rectum and they are hemodynamically stable, you do not have to do an upper endoscopy to exclude an upper GI bleed because they don't have one. Rarely, right-sided colonic bleeds can present with melena as well, and presumably small bowel bleeds can present with melena also occasionally. So now let's talk about assessing the severity. So as I said, there are two things you have to assess. The first one is the hemodynamic status on presentation. So if a patient has a resting tachycardia, they've lost about 15% of their circulating blood volume. If they have orthostatic hypotension, they've lost about 20% of their circulating blood volume. And if they have supine hypotension, they've lost about 40% of their circulating blood volume. So you can see it's fairly easy to calculate how much fluid or how much volume you should replace initially. Because men have a blood volume of about 75 cc's per kilogram, and women have a blood volume of about 65 cc's per kilogram. So you just multiply that by their estimated volume loss, and you have the amount of fluid that you should give them. The second thing is to assess the amount of ongoing bleeding. And that you assess by seeing if they're continuing to have any overt bleeding, such as melena, hematemesis, or if they're continuing to have blood per rectum. A persistent tachycardia suggests that the patient is still bleeding. And the lack of response to volume administration also suggests that the bleeding is ongoing, because they really should become stable after administering a liter of fluid. If the hemoglobin doesn't go up by 1 gram per unit transfused, then that also suggests that blood loss is ongoing. The next thing is to resuscitate the patient. And there are several aspects to this. There was a paper that came out from China which said that about 10% of patients with an upper GI bleed also had an acute coronary syndrome. So I think that this is important to remember in an elderly patient or in a patient who has a history of coronary artery disease. So you should get an EKG and ask about symptoms such as chest pain and shortness of breath. The second thing that we have to deal with is the coagulation status. And this is a very good reference that kind of, tells us, suggests how we do that. So the first thing we'll deal with are platelet issues. So platelet dysfunction is most commonly due to drugs, but it can also be due to medical conditions such as uremia or myeloproliferative disorders. It's suggested that platelet transfusion should not be given routinely to patients on antiplatelet drugs. For ongoing bleeding, but no platelet dysfunction, they should be transfused if the platelet count is less than 50,000. If there's ongoing bleeding, but the platelet dysfunction is present, then you should transfuse at a level of 75,000. And we like to have a platelet count of above 50,000 for endoscopy so that we can do our therapeutic maneuvers safely. Low-dose aspirin that's being used for primary prophylaxis can be held. However, if aspirin is being given for secondary prophylaxis, that should be continued. And if it's stopped for some reason, it needs to be restarted as soon as hemostasis is achieved, preferably within 3 to 5 days. Continued use of aspirin after a lower GI bleed is associated with an increased chance of rebleeding, unfortunately, but it's also associated with a decreased risk of cardiovascular events and death. So we can generally deal with a rebleed, but it's much more difficult to deal with a stroke or an MI. So the heart or brain always wins over the GI tract. If low-dose aspirin is being used as part of a dual antiplatelet regimen, that should be continued, and the other agents, such as Plavix, should be stopped and resumed within 5 days. And this strategy is associated with a low risk of adverse cardiovascular events, which is really the thing that we worry about. Dual antiplatelet therapy must be continued if an acute coronary syndrome occurred within the past 90 days, or a bare metal stent was placed within the past 6 weeks, or a drug-eluting stent was placed within the past 6 months. Let's talk a little bit about patients who are on anticoagulation. So PCC is preferable to FFP or vitamin K for patients with a GI bleed on warfarin who need to be reversed. We can do endoscopic therapy effectively and safely with an INR of less than 2.5. It is recommended that pharmacologic agents not be used to reverse patients who are on DOACs because the effect of the DOAC is relatively short, fortunately. Oral anticoagulants being used in patients with atrial fibrillation should be held and then restarted when the bleeding stops, again, preferably within 7 days. Restarting the warfarin and the DOACs post-bleed is associated with a lower risk of thromboembolism, and again, that's what we worry about. The different DOACs are thought to have different risks for GI bleeding, and it seems that there's some evidence that apixaban may be associated with the least GI bleeding. So if somebody is bled and they're on another DOAC or warfarin, then it's worthwhile considering switching to apixaban. And of course, there are other drugs that interfere with hemostasis. Of the prescription ones, the most common ones would be the nonsteroidal anti-inflammatory drugs, the SSRIs, and salacitol. And it's important not to forget that the SSRIs can do this. And if a patient is continuing to bleed and they're on an SSRI, that SSRI should be stopped. And interestingly enough, there was a study of post-PEG bleeding, and it turns out that the risk of bleeding was much greater for patients on an SSRI than on a patient who was taking the dual antiplatelet therapy. And of course, unfortunately, there are multiple non-prescription meds that can affect hemostasis. These are mostly nutritional supplements and herbal supplements, and that's why we recommend that these things be stopped, a week before an elective procedure. Bleeding in the cirrhotic patient is another unique problem. Advanced child's class, acute on chronic liver failure, and acute kidney injury increase the risk of bleeding in cirrhotics. There's no direct evidence that conventional laboratory tests, including the INR or platelet count, accurately predict bleeding risk in a cirrhotic. There is some in vitro evidence to suggest that a platelet count of greater than 55,000 may lead to improved hemostasis. Cryoprecipitate to try to get to a fibrinogen level of greater than 100 to 120 may also be helpful. And again, cryo is preferable to FFP because of a smaller volume load. The next thing that we have to worry about is volume resuscitation. And again, a very important thing is adequate access. So we generally recommend 2 18-gauge peripheral IVs or central access if you can't get good peripheral access. Usually we use crystalloid, either normal saline or Ringer's lactate. And unless somebody is in florid congestive heart failure, you can safely give them 500 cc's over 30 minutes with a maintenance rate of 200 cc's per minute until they're stable. And the goal here is to maintain a mean arterial pressure of between 65 and 70, because that's the pressure that's necessary for adequate tissue perfusion. In the intensive care unit, there have been multiple studies trying to use other things like head of starch and all that other stuff, but they were actually associated with more adverse events. So we just stick with good old-fashioned saline or Ringer's lactate. As far as blood products, a type and hold should be active at all times. If the patient is hemodynamically stable, then you transfuse them when they reach a hemoglobin of 7. If they're hypotensive, then they can be transfused prior to that point. It's important to not overtransfuse a cirrhotic, as that can increase their portal pressure and precipitate a variceal bleed. If the patient has pre-existing cardiovascular disease or an acute coronary syndrome, then transfuse at a hemoglobin of 8. And patients who require massive transfusions, and each hospital has their own protocol, may need plasma, cryo, and platelets. And of course, monitoring is extremely important, because monitoring the hemoglobin shows us if the patient is continuing to bleed in the absence of overt bleeding. So if you're not sure about the status of hemostasis, then just monitor the hemoglobin more frequently. And it's also important to realize that equilibration occurs 15 minutes after transfusion in a non-bleeding patient. So you don't have to wait a long time after transfusion to start monitoring them to see what's going on. And the last thing is whether to get a surgery consultation. I think that surgery should be consulted if the patient is hemodynamically unstable despite adequate volume resuscitation, or if there is ongoing overt bleeding. And the generally acknowledged indications for surgery is massive bleeding in patients that are too hemodynamically unstable for any other therapy, or just persistent bleeding despite attempts at endoscopic or radiologic therapy. It's very important in a lower GI bleed to try to locate the site of colonic bleeding prior to surgery, as blind resections will not successfully control the bleeding if the surgeon cut out the wrong part of the colon. And if that happens, this is associated with considerable morbidity and mortality. So now let's talk about some general lower GI bleeding considerations. Lower GI bleeding accounts for approximately 30 to 40% of all GI bleeding. The in-hospital mortality is generally between 2 and 4%. This compares to the in-hospital mortality of about 10% with an upper GI bleed. However, the mortality is greater, less than 20%, if greater than 40 units of packed cells are transfused. And the risk factors for a poor outcome include basically what you would expect. They include a hemodynamically unstable patient, on presentation with a systolic blood pressure of less than 100, a pulse greater than 100, or a hematocrit less than 35, and continued bleeding in the hospital with need for transfusion, multiple medical comorbidities, age greater than 60, creatinine greater than 1.7, and of course, recent use of medications that decrease hemostasis do not help the situation. The good news, however, is that 80 to 85% of lower GI bleeds will stop spontaneously. So now let's talk about some specific etiologies of lower GI bleeding. And this is just a list, and you can see that, by far the most common ones are diverticulosis, ischemic colitis, and hemorrhoids. And these are the ones that we'll talk about a bit. So let's talk about diverticulosis. Diverticulosis is common, and fortunately, most of them don't bleed. 2% of patients with diverticulosis will bleed at 5 years, and 10% will bleed at 10 years. Typically, a diverticular bleed is not accompanied by significant abdominal pain, but they can have some lower abdominal, relatively minor cramping. In the West, left-sided diverticula are most likely to bleed, and in Asia, right-sided diverticula are more likely to bleed. Thankfully, about 75% stop spontaneously, but unfortunately, there is a significant rebleed rate. 25 to 35% will rebleed in 4 years. And risk factors for bleeding include aspirin and nonsteroidal anti-inflammatory drugs. Active bleeding can be treated endoscopically with clipping, epinephrine injection, BiCAP, and most recently band ligation, which may actually be the most effective modality. But banding shouldn't be done in the right colon, as that may result in perforation because the right colonic wall is so thin. And epinephrine, as in upper GI bleeds, is generally used in combination with another therapy. Fortunately, colonoscopy is about 92% successful in accomplishing initial hemostasis. And this is just the result of a study of 118 patients with definitive diverticular bleeds, which means that at the time of colonoscopy, they actually saw a diverticulum bleeding. So in those patients who did not get endoscopic therapy, 65% of them continued to bleed. But in those who got endoscopic therapy, only 6% continued to bleed. In those not receiving therapy, 43% needed surgery or embolization. In those getting therapy, only 2.5% did. And here, not getting endoscopic therapy was associated with longer days in the hospital and more complications. So this is just a slide of the microvascular anatomy of diverticulum. And you can see that the things that bleed mostly are arteries at the bottom. And this has a dual supply. It gets blood from arteries that are actually inside the wall of the colon and those that are actually in the mesentery outside of the wall of the colon. And this is just an example of therapy. If you see a bleeding point at the neck of the diverticulum, then you first inject it with epinephrine to slow it down so you can more accurately target your thermotherapy. And again, this is exactly like an upper GI bleed. And again, the epinephrine is rarely used by itself. It's generally used in combination with something else. And this is just a beautiful picture of an actively bleeding diverticulum. Here's the tick here, and here's the blood. And here's the picture of a visible vessel, which is at the neck of a diverticulum. And this looks exactly the same as a visible vessel at the base of an ulcer. And it's important to not only treat actively bleeding diverticula, but also to treat non-bleeding stigma of diverticular bleeding, which is basically an inherent clot or a visible vessel. And the reason for that is that 53 or 60 to 65% of patients with non-bleeding stigma will go on to bleed. And if you treat them endoscopically, then in one study, no patient went on to bleed, and in another study, only 2.5% rebled. And again, this is just a picture of a clip applied to a diverticulum. And again, we generally try to use 2 clips to deal with the dual blood supply. Let's go on now to talk about ischemic colitis. Colonic ischemia is more common than small bowel ischemia or mesenteric ischemia. It can be due to acute embolic or thrombotic arterial occlusion or to venous thrombosis, but most often it is due to non-occlusive hypoperfusion causing ischemia, which is why with colonic ischemia you do not need to get a formal angiogram because most of the time there's no actual blockage. Some studies have demonstrated an increased prevalence of thrombophilic disorders, such as the antiphospholipid syndrome and factor V Leiden mutations. The left colon is affected 75% of the time, and the most commonly affected areas in the left colon are the splenic flexure and the rectosigmoid junction, the so-called watershed areas, as they have the least collateralization of flow. Isolated right colonic ischemia has a worse prognosis, probably because of coexisting mesenteric or small bowel ischemia. Older age and female gender are 2 risk factors for ischemic colitis. The typical presentation of ischemic colitis is lower or left-sided crampy abdominal pain and fecal urgency with bloody diarrhea or rectal bleeding developing within 24 hours of the onset of the abdominal pain. But ischemic colitis can present as bleeding without abdominal pain. And conversely, 15% of patients have abdominal pain without bleeding, but this portends a poorer outcome. Most patients with non-occlusive colonic ischemia improve within 1 or 2 days and have complete clinical and radiologic resolution within 1 to 2 weeks. But you can have adverse sequelae. You can get gangrene or necrotic bowel in 15% of the time. 20% of the patients develop chronic ischemic colitis, and those with chronic ischemic colitis can develop a colonic stricture within 3 to 6 months. An increased lactate level, LDH, and CPK may indicate advanced tissue damage, so it's good to order those blood tests. And a leukocytosis of greater than 50,000, a BUN greater than 20, hemoglobin less than 12, LDH greater than 350, and a sodium less than 136, along with metabolic acidosis, may indicate infarction. There are several other conditions that are associated with ischemic colitis. For example, there are some medical conditions, MI, CHF, hemodialysis, and small vessel disease such as diabetes and vasculitis. There are surgical conditions that are also associated with ischemic colitis. For example, any sort of aortoiliac instrumentation or surgery, such as repair of an aortic aneurysm or a history of cardiopulmonary bypass. And then there are some lifestyle things that can be associated with ischemic colitis. Extreme exercise or long distance running being some of them. It's very important to remember that conditions that increase the intraluminal pressure or diameter can be associated with ischemic colitis as well. And that's because the tension in the colonic wall is equal to the pressure times the radius. And mural tension is associated with colonic ischemia because it compresses the blood vessel and thereby compromises the circulation. So you have to be careful of colonic ischemia and any cause of mechanical obstruction, especially cancer, because that increases to an increased colonic diameter and ischemia. Similarly, Ogilvie syndrome, non-occlusive colonic dilation with a cecal diameter greater than 12 centimeters can perforate, again, because they get focal ischemia. And we have to be careful of overinsufflation of the colon because that can cause colonic ischemia as well. And that actually has happened to me one time in my career. And unfortunately, of course, it was the mother of one of my closest friends. So it does happen. There are some drugs that are associated with ischemic colitis. There's reasonably good evidence that constipation-inducing drugs, such as opiates, can do it, as well as some immunomodulators and amphetamine and cocaine. And we certainly have seen here amphetamine and cocaine cause mesenteric ischemia. And there are a bunch of other drugs which the evidence is less robust for that may be associated, and female hormones are among the most common ones of that lot. CAT scan is the imaging modality of choice, and what you see is bowel wall thickening and pericolonic fat stranding. So here you see the lumen of the sigmoid colon, and you can see that the wall is really thick. And here you can see that the mesentery is dirty around the colon, and that's the pericolonic fat stranding. Pneumatosis and portal vein mesenteric venous gas are suggestive of transmural infarction. So here you can see the liver, and here you can see air in these vascular structures. And this is portal venous gas, and this is really bad. And you know that this is air in vascular structures because they extend to the periphery of the liver. Intrahepatic bile duct dilation is generally more central. And there are various changes that you can see on colonoscopy. So early on, you get what's called a colopathy. This is within the first 24 hours. And you can see that the folds of the colon are very thick and purple. And then after 1 to 3 days, you actually get a colitis, where you get actual inflammation of the wall, and you can see ulceration and friability. And there are distinctive changes of colonic ischemia if you biopsy the colon. For example, you can get crypt atrophy, which is small crypts. You can get hemorrhage, lamina propria hyalinization, which means that the lamina propria is filled with this homogeneous pink stuff, and you can get infarction and ghost cells. And infarction is frankly dead colon, and ghost cells are dead individual cells. And this is what's called the colonic single stripe sign. And it's basically a linear ulcer running along the length of the colon. And this is actually fairly specific for colonic ischemia. Unfortunately, this is gangrene. This is a dark, black, dead segment of colon. And here you can see it as well. This is purple colon. You never want to see this. It's very important to realize that colonic ischemia can mimic an ulcerated mass resembling colon cancer. And this is a barium enema, and you can see this is a typical appearing apple core lesion, which you would see with colon cancer. And here is what was seen colonoscopically. You see an ulcerated mass, but this was not cancer. This was in fact colonic ischemia. So it's very important that you never tell a patient that they have colon cancer until the pathology report is back. And this has happened in my practice 2 to 3 times. And this is just the histology of mesenteric ischemia. And here you can see that the epithelium is infarcted, and that's because the epithelium is the most susceptible to vascular compromise because of the vascular anatomy of the colon. And these are ghost cells. These are individual cells of the crypt that are dead. Let's talk about post-polypectomy bleeding now. There are several risk factors for post-polypectomy bleeding. A very important one is the polyp size. And that is for polyps that are 10 millimeters or less, the risk of delayed bleeding is only about 1%. But for those over 20 millimeters, 2 centimeters, the risk rises to at least 6.5%. And there are other risk factors as well. For example, a pedunculated polyp with a thick stalk, that's an increased risk to bleed. Older patients, polyps in the right side of the colon, especially the cecum. If a patient has a bunch of comorbid diseases or chronic renal disease, and of course, patients who are on anti-hemostatic drugs. And that's why there's a recommendation for us to clip thick polyp stalks and also to close EMR defects in the right side of the colon. Post-polypectomy bleeding occurs about 5 to 7 days after the polypectomy, but it can occur up to 30 days later, presumably due to delayed tissue damage. Delayed bleeding is associated with the use of more coagulation current as opposed to cutting current, and cutting current is associated with more immediate bleeding. The new kid on the block is cold snare polypectomy, which is basically doing a polypectomy without the use of current. You can't do this with all polyps, but when you can, it actually is associated with a negligible risk of delayed bleeding and is being used more frequently in larger polyps. And this is the method that I try to use whenever I possibly can. 22% of patients who undergo colonoscopy for post-polypectomy bleeding can have a site identified, and the number needed to treat is 4.5 patients. And this site can be endoscopically treated if you see it. Requiring a blood transfusion and a drop in hemoglobin of greater than 2 grams per deciliter are predictors of the need for therapeutic intervention. And having bloody bowel movements more frequently than every 2 hours suggests ongoing bleeding. Minimal or no bleeding suggests that the bleeding stopped. And the good news is that if the bleeding is stopped by itself, it is very unusual for it to resume, so there is no need in that circumstance to do a colonoscopy. Endoscopic clipping may be the modality of choice to treat a post-polypectomy bleed because it does not cause further tissue damage as does thermal methods. And the injection of epinephrine tends not to be as effective because post-polypectomy scarring limits its infiltration into the tissue. We'll talk about now colonic angiotasia, and this is an example of a colonic angiocasia. And you can see that it does have a distinctive structure. It has kind of a spidery pattern of blood vessels. Colonic angiocasia is the most common vascular lesion generally seen in patients over the age of 50. They are generally located in the cecum and ascending colon. It may be due to intermittent obstruction of submucosal veins causing dilation of the blood vessels. But colonic angiocasia are also associated with the left ventricular assist device and aortic stenosis, or really any other significant valvular heart lesion. And when bleeding from angiocasia are associated with aortic stenosis, it's called Heide syndrome, and there's often an acquired von Willebrand syndrome along with it. Bleeding from colonic angiocasia can cause obscure bleeding leading to iron deficiency anemia, or it can cause overt painless bleeding. And the endoscopic treatment, again, is epinephrine injection, BiCAP, or APC. And of course, angiography can be done in a massively bleeding, hemodynamically unstable patient or for a failure of endoscopic therapy. And this is just a picture of thermal therapy being applied to colonic angiocasia. Next, we'll talk about radiation-associated vascular ataxia, which I will call RAVE from now on. So RAVE are dilated blood vessels that occur after radiation therapy. Again, it can bleed occultly, causing iron deficiency anemia, or overtly causing rectal bleeding. It can occur months to years after radiation due to ongoing vascular damage. So unfortunately, radiation therapy is a gift that just keeps on giving. Endoscopic findings include vascular telangiectasias, friability, and mucosal pallor. And here you can see the red vascular telangiectasias, and you can see the extremely pale mucosa that's in between. Supraphate enemas, APC, and BiCAP can be used to treat symptomatic lesions. And I think that it's important to understand that you just want to treat symptomatic lesions because application of the APC can cause ulcers, which can subsequently go on to bleed. So you really want to treat only if there's a very good reason to. Now, RAVE is distinct from radiation proctopathy, which is the other GI sequela. And radiation proctopathy is due to inflammation, which can be associated with fecal urgency, rectal pain, diarrhea, or constipation. So now let's talk about some diagnostic and treatment modalities. And these are the ones that we're going to talk about. So let's talk about colonoscopy first. In 2016, the AGA put out, the American College of Gastroenterology put out guidelines for lower GI bleeding, and they stated that colonoscopy was the initial diagnostic procedure of choice. Well, fortunately, it's safe. There's a less than 2% complication rate when it's done in the setting of lower GI bleeding. But the chance of finding a definitive source of the bleeding is low. In other words, the chance of finding an actively bleeding lesion is low. And in one study of 39 patients that were colonoscoped urgently for lower GI bleeding, a definitive source, that is, the lesion actively bleeding, was found in only 3. A probable source, which means a lesion that potentially can bleed, was found in 26, and no source was found in 10. Importantly, there was no difference in the length of the hospital stay, time to resolution of bleeding, the need for transfusion, chance of rebleeding, the need for surgical intervention, or mortality between those patients colonoscoped urgently and not urgently. So now let's talk about CT angiography. So in 2019, the British Society of Gastroenterology declared that CT angiography was the initial diagnostic test of choice. It can detect bleeding at a rate of 0.3 to 0.5 milliliters per minute. It can precisely localize the origin of the bleed because it's associated with an imaging modality, which is CT. It's really quite sensitive. 79 to 95% of bleeding lesions will lead to a positive test. It's also quite specific. 95 to 100% of non-bleeding lesions will lead to a negative test. And it's also very accurate. It's associated with very few false positive or false negatives. And in fact, in one study, the accuracy was 100%. A positive CT angiogram significantly increases the chance of localizing the bleeding source with colonoscopy. And 85% of patients with a positive CT angiogram have a positive mesenteric angiogram. Very importantly, it has a high negative predictive value as well, which means that 82 to 90% of patients with a negative CTA will not rebleed during that hospitalization. And this is just an image of a positive CTA. And here you can see probably the sigmoid colon, which is a little floppy because it's on the right side. Here you can see diverticulosis, and here you can see active extravasation. So this is actually probably a diverticular bleed. So now let's talk about the nuclear medicine bleeding scan. So to do a nuclear medicine bleeding scan, the patient's own red cells are labeled with technetium 99 per technate and then reinfused into the patient, and the patient is scanned. It is the most sensitive diagnostic modality as it can detect bleeding at a rate of 0.1 to 0.3 milliliters per minute. However, despite its sensitivity, it is positive less than 50% of the time. And unfortunately, when it's positive, the site is not accurately localized in up to 33% of the time because it can only localize bleeding to an area of the abdomen. It cannot locate it to a specific location because it does not have an associated imaging modality. For example, the tracer in the right lower quadrant may be located in the right colon or a redundant sigmoid colon. Mesenteric angiography must be done immediately after a positive scan for accurate localization and treatment. This is an example of a positive bleeding scan here in the right lower quadrant, and you know it's a true positive because as time goes by, you can see that the tracer is traveling down the colon. And lastly, we'll talk about an angiogram as enthusiastically endorsed by Oprah. So mesenteric angiography can detect bleeding at a rate of 0.5 to 1 milliliter per minute. It should be done as soon as possible after a positive CTA or nuclear medicine bleeding scan, as bleeding can be intermittent. It can be done as an initial study in hemodynamically unstable, actively bleeding patients. And if this is the first test that's done, then they inject the SMA first, and if that doesn't give the answer, they inject the IMA, and if that doesn't give the answer, they inject the celiac axis. And this approach is successful 25 to 70% of the time to localize the source of the bleed. As far as therapy goes, superselective embolization of the distal branch of the bleeding blood vessel with microcoils or sealants is the preferred treatment method. If that can't be done due to technical reasons, then vasopressin is infused. Now, the technical success of angiography, in other words, the chance of successfully being able to administer therapy is 93 to 100%. Clinical success, in other words, actually working to stop the bleeding, is 63 to 96% of the time. However, it is unfortunately associated with some adverse events. You can get ischemic bowel in 1 to 4% of the time, and you can get complications of the arterial puncture, including bleeding and pseudoaneurysm formation. And unfortunately, there is a significant rebleeding rate of between 10 and 50%. And for example, angiocasia rebleeds 40% of the time. And this is an example of a wildly positive mesenteric angiogram. So now let's go through some illustrative cases. So case one, we have a 76-year-old man with a history of hypertension, CAD, history of MI, who had a PCI 3 years ago, who is on aspirin. There's no history of CHF. Several hours ago, he had 2 episodes of bright red blood per rectum with minimal lower abdominal crampy pain. No chest pain, no shortness of breath. He came to the emergency room where he had several episodes of bleeding over several hours. His pulse was 112, his blood pressure was 140 over 85, he was afebrile, his abdomen was soft without tenderness. On rectal examination, there was no bleeding fissure, and anoscopy was negative for bleeding hemorrhoids. His hemoglobin was 12, he had a normal MCV, platelet count was 300,000, INR was normal, EKG showed mild LVH, normal sinus rhythm, no acute changes on the EKG. So, what do we do? Well, first of all, let's figure out about the localization of the lesion. So, he has bright red blood per rectum without hypotension, so this is probably a lower GI bleed. So we assess him. He has resting tachycardia, so he is volume depleted. As far as ongoing bleeding, well, he may be having an ongoing bleed because he continues to pass blood in the emergency room. As far as resuscitation goes, he has nothing suggestive of an ACS. The EKG is not worrisome, so you don't have to get your cardiologist. As far as coagulation, platelet and INR are normal. He is on aspirin, and this should be continued because he's on aspirin for secondary prevention. As far as volume resuscitation, as always, we need adequate IV access. We can use crystalloid. We do not need to use packed cells because his hemoglobin is greater than 8. As far as surgery consultation, not a bad idea because, again, there's a question of active bleeding. So how do we analyze this? Well, the painless lower GI bleed suggests diverticulosis or angiocasia. A perinatal source was ruled out on physical examination and anoscopy. So I think that in this case, a reasonable plan would be to get a CTA as soon as possible when he passes blood next. Case number 2. A 65-year-old female with a history of hypertension and diabetes who 12 hours ago had severe colicky left-sided abdominal pain. A few hours after the pain began, she passed bright red blood. She had mild squeezing chest pain that resolved. She had no further overt GI bleeding in the emergency room. On physical examination, her temperature was 38, pulse at 85, blood pressure was 120 over 72. On physical examination, her abdomen had a tender left lower quadrant with some tensing to moderate palpation. She had bowel sounds. Laboratory, she had a leukocytosis. Her hemoglobin was 8.3, platelet count normal, PT normal, INR was normal, normal BNP, albumin, LDH, and lactate. EKG showed newly elevated ST segments. So, as far as the localization, again, this is probably a lower GI bleed as she has bright red blood per rectum without hypotension. As far as assessing her, she has no evidence of significant volume depletion at the current time, and there's no evidence of active bleeding. As far as resuscitation, well, there is something to suggest that she may be having a coronary event. She has some chest pain, and she has an abnormal EKG. So a cardiologist should be called. As far as coagulation, PT and the platelet and iron are normal, and she's on no anti-hemostatic drugs. As far as volume resuscitation, again, always make sure they have IV access. Crystalloid can be used for maintenance. She does not need pack cells, as her hemoglobin is more than 8. Surgical consultation, not needed currently. So how do we analyze this? Well, the clinical presentation and the leukocytosis suggest a colitis, an inflammation of the colon. Maybe ischemic, she is a woman, which puts her a little bit more risk. Infectious, less likely IBD. So I think that a reasonable plan here would be to get a CT, looking for evidence of colitis, as well as stool studies to rule out an infection. Case 3, 62-year-old female with a history of coronary artery disease and atrial fibrillation on Xarelto, had a colonoscopy 4 days ago for colon cancer screening, at which time a 3-centimeter fecal polyp was removed by EMR. The defect was not clipped closed because it was deemed to be too large. Xarelto was restarted the next day. For the past 6 hours, she has been having bloody bowel movements every 30 to 60 minutes. She denies abdominal pain, chest pain, or shortness of breath. On physical examination, her pulse was 115, blood pressure 130/80 with orthostatic changes. Her abdomen was benign. Her hemoglobin was 7.5, platelet count was normal, INR was 1.4, BNP normal, EKG showed rapid AFib with no ischemic changes, and in the ER she continued to pass blood per rectum. Well, this is a patient who has bright red blood per rectum with a history of a recent polypectomy and a normal BUN to creatinine ratio. So she probably has a lower GI bleed despite hemodynamic instability. As far as assessing her, on initial presentation, she has a resting tachycardia with orthostatic changes, so she is volume depleted. She may be actively bleeding because she continues to pass blood per rectum. Resuscitation, there's no evidence of an acute coronary syndrome, so we don't need to get the cardiologist. Her coagulation, she does have impaired hemostasis due to Xarelto. As far as volume resuscitation, again, as always, IV access is necessary. Her hemoglobin is less than 8 in a patient with a history of coronary artery disease, so she should get pack cells to get her above 8, and then she should be given crystalloid based on your assessment of her volume. As far as surgical consultation goes, not a bad idea because she is having evidence of active bleeding. So how do we analyze this? Well, unfortunately, this is probably a post-polypeggy bleed, and she has several risk factors. Unfortunately, the DOAC was started 1 day after and not 2 days after, even though EMR is considered a procedure that is high risk for bleeding. She also had non-closure of a right-sided EMR site, which is a risk factor, as is the fecal location. So what would I do? Well, if hemodynamic stability is achieved, I would treat her supportively, giving her pack cells as necessary until the Xarelto effect is gone. However, if hemodynamic stability cannot be obtained, or if there is a significant transfusion requirement, then colonoscopy with a same-day prep with the intent to treat the bleeding and close the EMR site is reasonable. Case 4, and this is actually a real case. An 82-year-old man with a history of pancreatic cancer, status post-liver resection, history of prostate cancer in remission, and a history of hypertension. The night prior to admission, he had several episodes of red blood per rectum associated with near syncope. He's had no bleeding episodes since then. He has no GI symptoms, no chest pain, no shortness of breath. There is no history of aspirin or NSAID use. On physical examination, his pulse is 105, his blood pressure is 108/65, and his baseline systolic blood pressure is around 130. On rectal examination, he has melena. His hemoglobin is 8.4. His BUN is 30, creatinine 0.82, platelet and INR are normal. His EKG shows a sinus tachycardia. So, this is a patient who passed bright red blood per rectum with hypotension and an increased BUN to creatinine ratio of greater than 25, as well as melena. So all this is very suggestive of an upper GI bleed. He is hypotensive and tachycardic, so he is volume depleted. Fortunately, there's no evidence that he's bleeding right now. As far as resuscitation, there's no suggestion of an acute coronary syndrome. His coagulation seems to be intact. As far as volume resuscitation, as always, you need IV access, that's adequate. You can give crystalloid. He does not need Paxos now, but of course the hemoglobin will have to be carefully followed because he may need it in the future. Surgical consultation is not needed right now. So, what's the analysis? Probable upper GI bleed. He needs an upper endoscopy. And in fact, he had a friable gastric cancer. Last case. So, this is a 50-year-old man with no significant past medical history who is at intermittent bright red blood per rectum for 2 months. He came to the emergency room under pressure from his partner because the bleeding has been increasing in quantity. His last bleeding episode was last night. He did not seek medical attention up until now as he, quote, hates doctors who are in it only for the money, close quotes. Also, his stools have been consistently thinner for the past 3 months. He has had an undesired 15-pound weight loss with no decreased oral intake. For the past month, he has had occasional mild left lower quadrant pain. He has no chest pain, and his family history is positive for colon cancer in his father at the age of 42. He has no history of taking aspirin or NSAIDs, and the only other medicine he takes is apple cider vinegar for general health maintenance. His pulse is 73. His blood pressure is 140/85, and he had a normal examination, including anoscopy. His hemoglobin was 7.7. His NCD was 61, which suggests iron deficiency. His BNP was normal. His platelet count was normal, and his PT and INR was normal. So, again, this gentleman had bright red blood per rectum without hypotension, so it's probably a lower GI bleed. He's hemodynamically stable with no evidence of active bleeding. As far as resuscitation goes, there's no evidence of an acute coronary syndrome. His coagulation is intact. As far as volume resuscitation, he just needs maintenance with crystalloids. No red cells are needed yet. Surgical consultation is not needed yet. My analysis, this gentleman has a history that's very suggestive of colon cancer. And this is somebody that I would colonoscope while he's in the hospital, as his antipathy towards the medical profession reduces the likelihood of him following up as an outpatient. So I do think that every case is individual, and you kind of have to customize your approach a little bit. So, what have we learned from all this? Well, I think that the most important message here is that you have to have an organized approach to any patient with a GI bleed. You have to try to localize the bleed, assess how bad the bleed is and what its state is, and if it's ongoing. And of course, you have to think about resuscitating the patient. Do not flood a cirrhotic with FFP in a futile attempt to improve the INR because it doesn't correlate with bleeding risk, and you won't be able to do it anyway, probably. The most common causes of lower GI bleeding are diverticulosis, ischemic colitis, and hemorrhoids, so don't forget to do the rectal examination. A negative CT angiogram is reassuring. Colonoscopy, for the most part, can be done electively. Make sure patients on aspirin or other anti-hemostatic agents that bled really do need to be on them. If you're not sure, then ask cardiology, neurology, vascular, or whoever put them on that drug. So thank you very much. Any questions?